I'd like to go ahead and start the webinar. I'm Bob Nickel. I'm director of the Mad in America Continuing Education Project, and I'd like to welcome everyone. We will get started very soon. I like to start things on time. People who know me know I run pretty tight meetings usually because I like to make maximum time for the presentation. And I'm very pleased that this is the second in our series on MAD studies. The title of our webinar, as you can see, is MAD Activism and Mental Health Practice. And our presenter today is Dr. Mohammed Rashad. And Dr. Rashad is probably the most diverse in terms of cultural and geographical background that we've ever had. His medical degree is from the University of Cairo. He's done research and some practice in South Africa, and for the last 15 or 16 years, he's been in the UK teaching and doing research, and we're very pleased to have him with us today. I always do a disclaimer saying what we're providing is information, not clinical advice in any way. And I don't think most people are signing on to get clinical advice, but we like to make sure that we're clear about that anyway. We're going to have about 55 minutes or so of presentation, and then we'll save the last 25 minutes for some questions, comments, responses. If Dr. Rashad doesn't have time to respond to all of them today, we'll do our best to see if we can get some responses after the fact. So bear with us as we go through this process. We do have continuing education credit 1.0 for psychologists, licensed professional counselors, marriage and family therapists, and nurses. Because of some other complications, we're not getting continuing education credits for social workers. I think without a lot further ado, I'd like to turn the presentation over to Dr. Rashad, and so take it away from here.
Thank you, Bob, for your introduction, and thank you everyone for being here for today's seminar on MAD activism and mental health practice. What I hope to achieve in this webinar is to give some ideas and to show that it is possible for mental health practice to be informed by ideas from MAD activism. That it's possible for mental health practice to be informed by diverse narratives of madness. To get to the point of being able to reflect on this today, there is quite a lot of ground to cover, as you can see in the following plan. Let me first mention a quick note on terminology. The term MAD activism, as I will be using it, refers to the third phase of mental health activism. I will talk shortly about the different phases. What is distinctive about MAD activism is that it is concerned with narrative, identity, and the meaning of certain kinds of experiences in a more direct and significant way than other phases. MAD pride is an example of MAD activism, but MAD activism is broader than MAD pride, as it includes identity-based activism that does not necessarily associate with pride. So this is the plan. Let me take you very briefly through the 6 areas that I want to cover. I will start by talking a bit about the different phases of mental health activism from the 1970s onwards. Then I will focus on MAD activism, on the elements of the discourse, and on the demands made by activists. Following from this, I will talk about identity in general terms, what it is, why it matters, and why people struggle for recognition of their identities. Then in section 4, I will introduce the different kinds of narratives of madness that we find in society. I will talk about 3 kinds of narratives: subjective, professional, and MAD narratives. I will attempt to demonstrate the shortcomings of some of the professional narratives, and I will argue that MAD narratives can correct for these problems. After this, I will move on to discuss 3 examples of MAD narratives: spiritual transformation, dangerous gifts, and healing voices. By the time we arrive to the final part, which is part 6, we are ready to consider how mad narratives can inform the clinical encounter. As you can see, there's quite a bit of material to cover, so let's get on with it. Now, when we look historically and when we also look across the different cultures of the world, we find that the term madness has meant and means a range of different things. For some people, madness is synonymous with creativity and subversion. For others, madness is associated with unreasonable, perhaps even dangerous behavior. For others, madness is associated with access to different realms and experiences, such as to spirits and spirituality. Among these diverse meanings of madness, there is one meaning in particular that has taken hold so deeply and systematically that it has become the default view in many communities around the world. The idea that madness is a disorder or a dysfunction or an illness of the mind. Now, medical interest in madness is not a new thing. Somatic theories date back to ancient Greece. By somatic theories, I mean theories that implicate primarily the body in the explanation of unusual mental states and behaviors. What seems to be a relatively new phenomenon is medical dominance over madness, something that can be traced perhaps to the late 19th century. So, for around a century and a half then, madness has been subjected to what I would like to refer to as a sustained process of medicalization, which is the attempt to subsume madness under medical and psychological idioms and the practices that come with them. So, for example, according to the dominant view today, madness would be classified in terms of the various subtypes of schizophrenia, bipolar disorder, and psychosis, and would be understood as a disorder of the mind caused by the interaction of multiple factors that include biological factors, psychological factors, and social factors. Now, this kind of view, which I'm sure all of you can recognize when you look around you in society, this kind of view has taken significant hold on, let's say, the cultural imagination. It has pushed aside alternative views. It has become fundamental to healthcare planning and funding at the governmental level, and it also defines the aims of local and global research programs concerning the causes of mental disorders and the interventions that can alleviate disorder. It also has become the main view endorsed by the general public, for whom the line of thought that mental illness is just like physical illness has become very commonplace. But things are changing. The dominance of the medical view of madness is being challenged within certain strands of mental health activism. Mad Pride activism, which Professor Ginger Hoffman spoke about in the first webinar, is an example of this form of activism. But how did we get there? Let me start with a brief account of the history of mental health activism. Of course, any historical account is necessarily one perspective, and it's not the only history that can be told, but it's one perspective that kind of tries to connect different phases that we have been through. So we can divide modern mental health activism into at least these three phases. There's an early phase, an early civil rights movement phase beginning in the 1970s, followed by consumer, survivor, and ex-patient movement, and the third phase is Mad Pride and Mad Positive activism. Today, elements of all three phases exist, but our focus in this seminar is on Mad activism, which is the third phase. Let me first say a few words about the first two to offer a kind of contrast. So the 1970s civil rights movement or movements in mental health, they emerged in the wake of Black, gay, and women's civil rights movement in the United States. Activists were organizing for the rights of users and survivors of psychiatric treatment, and for reform of mental health institutions. At the time, care in the community was a relatively new idea, and most individuals were in asylums. Now, these early groups had a clear civil rights agenda. They were concerned with abolishing involuntary treatment and prioritizing freedom of choice and consent above any other considerations. They also set up alternatives to the mental health system, such as self-help groups, drop-in centers, and retreats run by ex-patients and ex-inmates, as some at the time referred to themselves. The word inmate, of course, referring to the idea of that they were incarcerated in asylums. Now, an important name in this early activism, which you might have heard of, is Judy Chamberlain, who wrote this brilliant book, On Our Own. It was published originally in 1977. Judy Chamberlain's book was frequently cited by later activists as an inspiration. She wrote about the importance of consciousness raising, a concept that was borrowed from women's rights and from feminism. The idea, the process by which individuals who were ex-patients or who had some interaction with the mental health system can get together, share their experiences, and rid themselves of the idea that they are ill and that the medical profession is there to provide a cure. So this, in very, very broad, brief outline, is the essence, essentially, really the essence of the first phase of mental health activism, which had a very clear civil rights agenda. Now, moving on into the 80s and later than that, there are a different number of discourses began to emerge. Patients and ex-patients throughout the 80s began to be involved in policy meetings of mental health services, and their views began to be known. Now, the preferred terms changed. The notion of consumers and users of services became more prominent. Some consumer groups were not opposed to the medical model or to working with professionals in order to improve services. These developments were regarded by some activists as indicating what was referred to as a crisis of co-optation, the idea that the voice of mental health activists had to become acceptable to the profession, which required giving up on radical demands in favor of reform. Other activists rejected the term consumer, as it implied that patients and professionals were in an equal relation, with patients free to determine the services they receive, something, of course, that was not always the case. For these activists, they were not consumers, but survivors of mental health services. With survivor discourse, the connotations of the term patient are changing. Surviving here relates to having made it through the mental health system, through forced detention, aggressive, unhelpful treatments, through stigma, as well as for some individuals, the suffering they experienced, and which was labeled mental illness. In addition to this, the term survivor implies positive attributes. It implies resilience and strength, for example. Moving on to the third phase, which I'm referring to as mad activism, we can see that survivor discourse has already prepared the ground for mad activism. It did so by distancing itself from the term patient and its connotations, and also through the positive registers and attributes of survival. But it is only with mad pride discourse that the language of mental illness and the medical model as such are explicitly and unambiguously challenged. So let's get some background on the third phase of mental health activism, mad activism. According to one account, Mad Pride was born in the late 90s in the United Kingdom in the form of a direct action group. Within a few years, Mad Pride events were organized in many countries around the world. Mad Pride activists are clear about the radical nature of what they are attempting. In the introduction to this British anthology, Mad Pride, a celebration of mad culture, the editors actually, wrote the following. Mad Pride is said to become the first great civil liberties movement of the new millennium. Over the last century, giant strides forward were made by those asserting the rights and self-determination in the fields of race, gender, and sexuality. but mental health issues failed to keep pace. This is set to change. More recently, in the United States, Seth Farber, who wrote this book, The Spiritual Gift of Madness, said, "The Mad Pride movement is not merely a movement for mental patients' rights. It is a movement about the right to be different. In contrast to the survivors movement, which focuses on changing the mental health system, the implicit, if not explicit, goal of the Mad Pride movement is a transformation of society as a whole." I think Seth Farber uses the term survivor movement to refer to the earlier phase of mental health activism in general. I think he's not entirely correct in the connotations of surviving is not necessarily about reforming the mental health system. Anyways, in terms of Mad Pride, the idea then that there is a concern with what it is to be normal and not just with improving or reforming mental health services. So let's look in some more detail at Mad Pride discourse. Central to Mad Pride discourse is a reversal of the customary understanding of madness as illness in favor of the view that madness can be grounds for identity, such as in this quote from an advertising brochure for Mad Pride Hamilton. They say, "We are talking about mad people as a people and equity-seeking group, not as an illness. Madness is a political and social identity that we take pride in. As mad people, we have unique ways of experiencing the world, making meaning, knowing and learning, developing communities, and creating cultures." Now, rejecting the language of mental illness and disorder is central to Mad Pride discourse. To replace it, the term mad itself is reclaimed and its negative connotations replaced by more positive understandings, such as in these quotes. "Mad positive approaches do not pathologize me. Instead of being seen as someone who is sick, I am seen as someone who diverges from our traditional, narrow, exclusive, and discriminatory idea of normal." Another quote, "Madness is an aspect of my identity, who I am and how I experience the world, not an illness that is separate from me or a collection of symptoms I want cured." Now, this identity naturally has its own unique content, the ideas and the narratives that make it up. And we will look at some of these ideas later on when we discuss mad narratives. For now, let us stay with Mad Pride and look at what the demands are. Now, from the discourse of Mad Pride emerges a clear demand, expressed unambiguously in these quotes. "I need the world to be different so that I can thrive as the person that I am. As mad people, we have rights to be ourselves, just like everyone else." So there is therefore an expectation for society to change, to accommodate this different, diverse and unique identity. And a major site of change is the language that dominates public and professional narratives, a language in which key terms all indicate deficit and pathology, terms like disease, illness, disorder, as well as delusion, hallucination, and madness itself prior to its reclamation by activists. Now, a key difference between mad activism and other endeavors that focus on service improvement is that mad activism formulates the problem as one to do with respect and recognition. What is at stake is the entire way in which people's identities are publicly represented and valued, with the dominant reductive view of madness as a disorder of the mind being seen as an insult to a positive identity. Now, perhaps you can notice that there is an obvious commonality here with other social movements. Other social movements that have also campaigned around issues to do with respect, identity, and recognition. So, for instance, in the domain of sexual orientation and gender, for example, with gay rights and trans rights, activists are not only concerned with counteracting discrimination in, say, employment opportunities, but with something much larger than that, with achieving symbolic and cultural reparation in the wider society. A key aim then is for being gay or being transgender to be viewed as a valid way of life, and for individuals to develop positive identities that society would recognize and reflect back to them as such. So this is a brief account of activism in mental health, the three phases that I have been mentioning, with a focus on the latest phase, which is Mad Pride activism. As should be clear by now, the issue is centrally framed around the notion of identity. It would help then to get a sense of what identity is and why it matters. To put it as simply as possible, identity is a person's understanding of who they are, how they think of themselves, as well as how others think of them. If you ask me about myself, about how I understand myself, my answer is what my identity amounts to. So, for example, I could say that I consider myself to be a person, a man, a philosopher, and a person who tries to be considerate and supportive towards his siblings, say. Now, these descriptions of myself address different dimensions of my individual identity, respectively, two, as you can see in the slide, a personal dimension and a collective dimension. What we are, the collective dimension is represented in what I said by my claim that I'm a man and a philosopher, say, whereas the personal dimension is about what I consider to be my personal attributes, things like being considerate, supportive, caring, selfish, kind, and so on. Now, when we talk about mad activism, mad identity, and recognition, what we are concerned with is the collective dimension, as this is where social and political contestation and debate and change are being demanded. The philosopher Anthony Appiah puts it like this. He says that the collective dimension of our identity consists in the intersection of the social identities that a person takes to be central to who she is, such as, say, being an African American heterosexual woman. Now, one feature of social identities is that in being social, they do not belong to one person only, even if they are central to that person's individual identity. There are social categories that already provide norms and scripts for how a person who identifies with this category should behave. Of course, these scripts are not fixed or uncontested. I go back to Anthony Appiah again, who explains it in this way. From this book, The Ethics of Identity, it's an excellent book, I really recommend it. So Anthony Appiah says the following. There is not just one way that gay or straight people, or blacks or whites, or men or women are to behave, but there are ideas around, contested, many of them, but all sides in these contests shape our options. Ideas around about how gay, straight, black, white, male, or female people ought to conduct themselves. These notions provide loose norms or models, which play a role in shaping our plans of life. Collective identities, in short, provide what we might call scripts, narratives that people use in shaping their projects and in telling their life stories. So to the extent that I identify with a specific social category and I find it or make it central to my individual identity, it becomes important to me how this identity is publicly valued and understood. Again, Anthony Appiah says, this is his words, my being, say, an African American, among other things, shapes the authentic self that I seek to express. And it is in part because I seek to express myself that I seek recognition of an African American identity. End quote. So the situation basically is this. Because there is a connection between my own individual identity and the social identity with which I connect, this means that the misrecognition of social identities through disrespect and the promotion of negative narratives concerning others extends to my individual identity. When people struggle for recognition then, they are attempting to fashion positive narratives pertaining to this particular social identity in society. And this is exactly what mad activism is trying to do, to advance narratives of madness that can counteract the prevalent narratives in society. So what other kinds of narratives of madness are there, and how are the narratives provided by activists any different? So when I say narratives of madness, what I really mean are the different stories that can and are told about the range of experiential, emotional, and behavioral phenomena that fall under the umbrella term madness. There are at least three varieties. So these are very general types as opposed to particular narratives. We're going to go to the particular narratives later on, but these are just general types. There are subjective narratives, professional narratives, and mad narratives. So by subjective narratives, what I really mean is the person's own account of their experiences and their elaboration of their beliefs. These are the same accounts that clinical psychiatry and clinical psychology would then redescribe and organize into symptoms, such as delusions, passivity experiences, hallucinations, or particular psychological processes. So the subjective narrative is really just an expression of the person's world. It's that person's attempt to convey the world to the individual they are speaking to. Now, one problem that could arise with subjective narratives is that they can be idiosyncratic and, in fact, quite subjective in nature. So the person might not be able to find validation in their community or their social circle. Now, of course, this can result to further isolation. One way of responding to this problem, to the problem of idiosyncrasy of the subjective narrative that may lead to lack of validation and social isolation, one way of responding is to try and place the subjective narrative in a broader and shared context of understanding. But of course, not any context will do. It has to be one in which the person can find a satisfactory meaning for their experiences. For this particular reason, in many cases, the professional narratives which most people end up facing cannot provide that context, as they cannot satisfy the thing they're going through. They cannot satisfy their actual experience. Let me try and explain to you or demonstrate in what way professional narratives cannot fulfill this role. Okay, so what do I mean by a professional narrative? Well, essentially, it's any systematic approach to madness, whether this is medical or psychological. By systematic, I mean that the narrative provides or seeks to provide or presupposes that one day it will arrive at a total view of the phenomena, from an understanding of how they come about to a framework for the treatment. So the medical model is a professional narrative, and the various theories in clinical psychology would also be professional narratives. Now, if you really go down to the very basic nature of professional narratives, you'd find that they are one of two types. What I have described as divisive and integrative. I mean, the words are self-explanatory, but what they divide and what they integrate will be clear in a second. Okay, so what is a divisive narrative? A divisive narratives involve a separation between the phenomena and the person. The technical term for describing this process is a hypostatic abstraction, but you don't have to worry about the term. What it really means is when you transform a predicate into a relation, which essentially means instead of saying honey is sweet, we say honey possesses sweetness. So instead of saying honey, one of the properties of honey is that it is sweet, we say that honey is there and sweetness is there and they just happen to be related. Of course, you can see here that this sounds a lot like clinical diagnosis. A clinical diagnosis is a divisive strategy in this sense. It transforms a human suffering into a human plus suffering. Instead of saying Ahmed is depressed, we say Ahmed has depression. Instead of saying Maria is schizophrenic, we say Maria has schizophrenia. Now, it's not really about the particular terms, just to demonstrate the particular move that a diagnosis makes. It takes away something from being part of who you are and puts it alongside as a separate thing attached to you for that particular moment, which is the idea of you having an illness or having a disorder. So, divisive professional narratives are obviously perfectly exemplified by clinical and psychiatric diagnosis. They separate the person from the problem and try and work on the problem to eliminate it or whatever it is that the professional wants to do. What about integrative narratives? So, integrative narratives are present in some psychological and some psychoanalytic frameworks. The basic idea is that the phenomena of madness are considered by an integrative narrative to be some sort of alienated mental content. This could be either understood, this idea of alienated mental content can apply to something like thought insertion or auditory verbal hallucinations. Or it could be understood as arising from psychological processes of which subjects need to be aware. In terms of theoretical frameworks, there are many. So the idea of alienation can be understood psychodynamically as the defensive objectification and exclusion of mental states that threaten integrity of self and self-esteem. It can also be understood phenomenologically as the appearance into consciousness of phenomena that are normally in the background of awareness. So the essence then of the integrative narrative is that the symptom is considered part of the person's psyche, but it's a part that the person is not fully aware of, and then the goal of treatment is not to further objectify these mental states by placing them alongside the person, but to find a way of integrating these mental states with a self that continues to experience these mental states as other than self. Now, of course, some people find divisive and integrative narratives to be helpful. Many people don't. And one reason why many people don't find them helpful is because these narratives cannot account or satisfy the experience itself, the experience the person is going through. Let me try and explain this point. Now, one problem with professional narratives in relation to phenomena of madness is that they take away, or rather the word is subvert, the person's speech of its actual reference in favor of the framework embraced by the professional. So, for example, if I see the doctor and I say, Mustafa is putting thoughts into my head, the doctor would translate this to, he, referring to me, he has a psychotic disorder if he was employing a divisive strategy, such as a psychiatric diagnosis. Or if I was saying a clinical psychologist, for instance, if I tell the clinical psychologist, Mustafa is putting thoughts into my head, she or he will say to me, he, referring to me, is failing to recognize that he is the author of his own thoughts. This is if the strategy was integrative. Now you can see clearly that in both cases, the upshot of this is that my subjective narrative, my account of what's happening to me, is redescribed in such a way that it loses its basic meaning. It is transformed into something else entirely. And this is why, for some people, for many people, in fact, professional narratives are unsatisfactory. They do not reflect their actual experiences. This takes us then to the third narrative I want to talk about. Remember that in the beginning I said there are three narratives I want to discuss: subjective narratives, the professional narratives, and mad narratives. So now we've went through the first two, and we arrived at the third, the mad narratives. So what do I mean by mad narratives? I'm referring here to accounts that have been developed by activists and people with lived experience in order to make sense of madness. Mad narratives are unique in that they are constructed to make sense of people's experiences without necessarily redescribing them in medical or psychological language. In that sense, they are more faithful to the experience of madness and are more likely to satisfy people's subjective accounts. So essentially then, mad narratives are constructed to correct for professional narratives and the fact that they are inadequate to deal with the experiences of madness. And they also correct for subjective narratives and their idiosyncratic character, because they are worked out in a group and therefore are more likely to achieve a degree of social understanding and acceptance. But of course, a mad narrative is unlikely to perfectly coincide with the person's own subjective narrative. Despite this, they offer a blueprint for a person to make sense of her experiences and to be able to adopt a broader and unifying perspective on what is happening to her. They bring the person into a community of people who understand her experiences without doing narrative violence to these experiences, as professional accounts are liable to do. So I've been referring to mad narratives from the beginning, and now I've introduced them. It's time to give some examples before we can then see how or whether it's possible for mad narratives to be included somehow in the clinical encounter. So I want to give some very brief notes about three actual types of mad narratives: spiritual transformation, dangerous gifts, and healing voices. There will be some references. If you want to get any more information, you find them at the end, in the final slide. So, narratives of spiritual transformation have long been associated with madness. Seth Farber, in The Spiritual Gift of Madness, notes that in the experiences of some people, madness has value, has the potential to shed light on the human situation, to promote spiritual growth. Now, spiritual approaches to madness are not surprising, given the commonality of spiritual concerns in the accounts of service users, activists, and people with lived experience. For example, Sally Clay writes, "Becoming mentally ill was always a spiritual crisis, and finding a spiritual model of recovery was a question of life or death." In their study, Making Sense of Madness, Geeky and Reed report that, quote, "One of the most pervasive features of how participants spoke about their experience was their interest in spiritual aspects. Now, spirituality for the participants covered broad ground, and the authors define it as follows: an inclination to view the experience of psychosis in terms of a broad framework of meaning, pertaining to how the individual views his or her relationship with the universe. That is, a tendency to place a psychotic experience in a metaphysical context where it is considered to reflect something of existential or moral significance for the individual." Now, narratives of spiritual transformation also recognize that contemporary beliefs and approaches to mental health, what I've been referring to as professional narratives, they deny the spiritual dimensions of madness. First-person accounts are full of examples where mental health professionals suppressed people's attempts to make sense of their experiences in spiritual terms, either through forced treatment or the categorical refusal to engage with their views. Such suppression was experienced as significant harm, as a tragic loss of something that is potentially valuable, and as an interruption of an important transformation, leaving people confused and lost. Narratives of spiritual transformation seek to address these problems by repopulating our cultural repertoire, by repopulating it with spiritual ideas about madness. Now, these ideas can range from Eastern mystical and spiritual traditions to radical ecological perspectives, which try and connect to the environment and connect to nature. Now, whatever the specific content, there seems to be a certain kind of structure to the spiritual narrative, to the radical transformative process. There's breakdown of the habitual experience of the body, self-world, followed by disintegration of the self, spiritual death, followed by guided attempts at reorganizing experience through the content of a particular spiritual narrative. And if this process succeeds and proceeds well, it can lead to transformation and spiritual rebirth. There is echoes here of the concept of metanoia, which Carl Jung referenced frequently in his his writings. And by metanoia, Jung meant something like a fundamental change of attitude, transformation of mind, and the rebirth of the spirit. Sorry about the light, it just went back on again. They have like they try to be eco-friendly, so the light has a timer, which is good, but you have to move every 45 minutes. So this is a very brief overview of the narrative of spiritual transformation. Another mad narrative I want to discuss, and you might have heard of, is the idea of the dangerous gift, because it was actually popularized by the Icarus project, which is a project that began in the United States. The dangerous gift narrative is really interesting because it kind of embraces this double-faced nature of madness, which is on one hand associated with distress and difficulties in social functioning, and on the other associated with the potential for creativity and unique vision. One of the founders of the Icarus project, the artist and activist Jax McNamara, who was diagnosed with bipolar disorder as a young woman, she describes the narrative in this way. She is also a poet, so she has a really beautiful way with words. She says, "I don't feel like there is this foreign evil thing operating in me, and that my goal is to eliminate it and tame it into submission." One of the most distressing things about the disease model of mental illness in our culture is that to have any periods of darkness or suffering is wrong. It means you're off the track. It means you need to be fixed. So the idea then that there is something valuable to acquire from the unique thought process associated with certain kinds of madness is central to the dangerous gift narrative. And so is the understanding that when this is not controlled in the right way, the individual could suffer. And this is Jax again with another quote. She says, "We have been given a sensitivity, a temperament, a disposition which can grant us access to a lot of beautiful things, and can also be extremely painful and destructive. It's our responsibility as individuals to try to learn how to take care of our dangerous gift. We need to stop putting all the focus and treatment on how we can make you stop being the person you are. How can we stop telling you that you are wrong if you experience these things? And how can we instead help you to learn how to handle your sensitivities? That you might make the transition from having these sensitivities overwhelming you to having these sensitivities be giving you information you can use." The dangerous gift narrative, then, you can see, unlike an illness narrative, it does not redescribe or invalidate the experience. What it does is place it in an interpretive context that gives it meaning and value while recognizing the difficulties that people can face. The final mad narrative I want to give some very brief notes on is the idea of healing voices. Healing, not hearing. Yes, healing voices. The hearing voices movement has actually been quite successful at advancing a perspective on voices that challenges the psychiatric view. So instead of regarding voices as a psychopathological phenomenon that has to be treated, the hearing voices movement portrays voices as a normal and meaningful human experience connected to a person's life story. In the book edited by Longden, Corstens, and Dillon, they describe it like this. Voices are regarded as messengers that represent important information about life problems, which can therefore be utilized as a means of solving social and emotional conflict. Underpinning this is the idea that the problem is not the voices themselves, but the relationship the person develops towards the voices. Voice hearers are encouraged to communicate with their voices in order to understand the origin and meaning, and to be able to cope with and learn from them. The notion of healing voices encapsulates this potential for growth. And the narrative of healing voices does not really commit to a particular view on the sources of the voice. Voice hearers are encouraged to develop their own understanding. Some may understand voices as spirits from a different world that have come to communicate with them, a very common view in many cultures around the world. Others may understand them as belonging to departed relatives and friends. Others may view them as divided parts of their own self. Whatever the presumed source, the key points are that voices provide information the voice hearer can use, and that developing a relationship with the voices is key to being able to cope with them and to utilize them for personal growth. So, these are brief ideas about 3 mad narratives. We can now consider the concern with which I started. Can these powerful narratives be incorporated in mental health practice? Can they become part of the clinical encounter? Now, to think closely about each mental health profession and the ways in which it can be amenable to mad narratives requires that we go into a lot of detail about each profession, its ideas, theories, and practices. But what I want to do is to discuss and raise a more general issue, which I think is quite foundational to this particular problem. So I want to introduce 2 concepts that, in my view, can put the clinical encounter in a more receptive position to mad narratives. These 2 concepts are secondary insight and identity making. I will be talking about psychiatry, but my account can also be applied to other mental health professions. My argument will be that a clinical encounter guided by these 2 overarching concepts can accommodate mad narratives within it. So let's begin. Every clinical encounter, at the very least, is framed by 2 crucial issues. The first is, what kind of understanding of the situation does the clinician in the room want the person to attain? And the second is, what is the therapeutic aim of the encounter as a whole? So we can say the first one is about understanding and the second one is about therapeutic aim. Now, to say that these 2 issues frame the encounter is to say that the way the encounter will proceed will depend to a significant degree on the answer one gives to these 2 questions. With regards to understanding, there are at least 2 options, primary insight versus secondary insight. With regards to therapeutic aim, we also have 2 options, symptom control and identity making. Psychiatry typically focuses exclusively on the first pair, on primary insight and symptom control. And if that remains the exclusive focus of psychiatry, it will not be possible to accommodate mad narratives in clinical practice. On the other hand, the other 2 concepts, which are secondary insight and identity making, can allow mad narratives to play a role in the clinical encounter. So let's discuss these concepts in some more detail and see why am I saying this. So let's start with understanding and with the usual focus in any psychiatric encounter, which is primary insight. In psychiatric practice, when the term insight is used, what is really intended is primary insight. But I've divided them here in order to have a contrast with secondary insight. So, primary insight is defined broadly as, and this is from a paper by Lincoln, awareness of having a mental disorder, of its symptoms, and of its implications. The clinical assertion, when a psychiatrist claims that the patient lacks insight, this really amounts to saying that the person in front of them is refusing to attend to their experiences within the discourse of illness and within the clinician's professional framework. The person, in effect, is refusing to go along with the psychiatrist and refusing to accept that both of them are tackling the same thing, which a psychiatrist would want to describe as the disorder. Now, the concept of primary insight closes off the possibility of working with mad narratives before the encounter even starts. It does so because it takes what the person says as evidence for illness and not as a possible take on a wide range of human experience and suffering. In fact, when the encounter is guided by the concept of primary insight, we risk ending up in an unproductive situation. Basically, it looks like this. The person does not consider herself to be affected by a condition. Her experience of an interaction with the world is not for her something separate from who she is. On the other hand, the psychiatrist is asking her to adopt a stance whereby she has or possesses or is affected by a certain condition. And then, after asking her to adopt this stance, the psychiatrist wants her to evaluate this condition negatively and to call it a mental disorder. Now, to say that these are demanding requirements to ask of anyone is an understatement. Is it really reasonable to expect a person to go along with such a radical reorientation towards her experiences? Just imagine getting your friend to change their mind about a tiny thing and how impossible that is. Of course, it's not reasonable. It's not reasonable to expect a person on a single encounter to simply to change their entire view of what's happening to them and to suddenly take it as if they have a disorder. So, unsurprisingly then, insight in this sense, insight in the sense of primary insight, is notoriously hard to achieve in clinical contexts. And when it is achieved, it occurs at the end of a protracted process that frequently involves coercive treatment, loss of freedom, and daily exposure to psychiatric and clinical psychological language. Primary insight, then, is not conducive to working with mad narratives in the clinical encounter. We need an alternative concept that can guide the encounter. That concept is secondary insight. So, suppose we give up then on primary insight, which we might as well call illness insight, as an aim for the clinical encounter, and attend to the situation as it is. What we have is this: fundamental disagreement between the psychiatrist and the person on how to understand the situation that is unfolding in the clinical encounter. Now, they can agree to disagree on what all of it means, but that would not make the situation disappear. The person is still presenting with beliefs, emotional states, and behaviors that have led through some sort of antecedent social process to the psychiatric encounter. How can the encounter proceed at this point? What should it aim for? A possible answer is to aim for secondary insight, which, in contrast to primary insight, does not require of the person to adopt medical or psychological language or theories. So what is secondary insight? Secondary insight refers to a person's ability to take an observer view of herself and to see herself from the point of view of social norms and values that she might not subscribe to or agree with, but can recognize as possessing some sort of consensus. It requires of the person to imagine her conduct from the point of view of the, let's say, the generalized social other, as well as the view of members of one's social circle. Secondary insight avoids the problems of primary insight. The problem of primary insight is that it boils down to agreement with medical authority, and it paralyzes the therapeutic relationship in an adversarial position by demanding of the person a highly unrealistic reorientation towards her experiences. By aiming for secondary insight, a person's understanding of the social effects and implications of her beliefs and behaviors are considered more relevant than her understanding of psychobiological theory or diagnostic classifications. Furthermore, and this is crucial, while it does require appreciation of what others' views and norms are, secondary insight does not require agreement with these views and norms. For this reason, a focus on secondary insight opens up the possibility for a cooperative, non-adversarial interrogation of the nature, origins, and meanings of the issues that led to the person seeing a psychiatrist. It opens up the possibility for working with mad narratives in the clinical encounter. So, going back to the two main issues which frame the encounter, as I said earlier, on the question of understanding, framing the encounter in terms of secondary insight and not primary insight is what we need to do. What about therapeutic aim? Now, as I mentioned earlier, there are two relevant therapeutic aims: symptom control and/or identity making. I say and/or because symptom control and identity making are not mutually exclusive. One can be concerned with constructing an identity narrative that can help one make sense of a range of experiences, while at the same time wanting and benefiting from symptomatic treatment for particularly distressing symptoms. However, what happens in psychiatry is an exclusive focus on symptom control, which can be harmful and obviously is not conducive to working with mad narratives in the clinical encounter. So identity making is a central concept, and we need to see how it can be incorporated into the encounter. So let me say a few words about what I mean by identity making. Assisting individuals with constructing an identity is a recognized aim in the philosophical literature. In an essay called Towards Humanism in Psychiatry, Jonathan Glover writes that one aim of a humanist psychiatry, here he calls it a humanist psychiatry, is to improve people's capacity for living a good human life. And among the many factors that enter into a good life, Glover considers self-creation to be of fundamental importance. Self-creation and identity making are similar concepts as I use them here. When people are distressed and are going through intense experiences, they may sometimes struggle to incorporate such experiences in their self-understanding, into their identity. And the humanist psychiatry can help individuals develop this kind of sense of understanding. Reflecting a similar concern, Jennifer Radin argues that, this is a quote, some of the task of attributing and constructing self-identity may be one that can be undertaken by others when the patient's own identity constructing capabilities are compromised. This task can be adopted among the goals of therapy. In his essay, How Do I Learn to Be Me Again?, another philosopher called Grant Gillett, a philosopher of psychiatry, he writes that when people are distressed, they need a guide, an informant, who engages them in a reasoned, respectful discussion that enables them to assume and enact identities and to live out life stories, each with its own unique value. So there are a number of contexts where people can be assisted with constructing and maintaining an identity informed by a mad narrative. Glover and Radin suggest therapeutic endeavors of the sort one would see in clinical practice. These are, of course, important, and it would be really useful to see more of these endeavors informed by diverse narratives. Gillis' suggestion of the need for a guide and an informant casts a wider net and highlights the important role of the many mental health groups and networks: the Hearing Voices Movement, Open Dialogue and Soteria, the Icarus Project, and Psychology in the Real World groups. These are all avenues where people can get together and try and develop a shared understanding of their experiences. In these cases, people act as guides and informants to each other. So a mad narrative really is just a shared understanding. And in this seminar, I outlined 3, but there are others that exist, and there are many, no doubt, that will be formulated in the future. Identity making, then, requires that one is supported in developing a personal understanding of their experiences, an understanding that is satisfactory to them, but that retains a basis in a broader and shared narrative. Each person, of course, will have different needs and will require different levels of support. Persons who experience unusual phenomena but are able to interact socially, join groups, and develop with others a new shared understanding of their experiences will require less support than those who experience social withdrawal and persecutory fears and struggle to interact with others. And I think determining the level of support that is required and the interventions that can help is something to be accomplished in conversation with the person and on a case-by-case basis. In summary, then, in order for mad narratives to have a place in the clinical encounter, the encounter needs to be guided by 2 main concepts. The concept of secondary insight places the encounter on the right footing and makes it possible for non-medical and non-psychological narratives to be introduced. The concept of identity making allows the kind of support offered to people in distress to be geared towards helping them incorporate their experiences in a self-understanding grounded in a shared mad narrative. Much of what I've been saying today is coming out in my book, Madness and the Demand for Ignition, in February 2019. To conclude, I want to make 2 brief points. There is an idea which I think is really helpful to bring back to earth, in a sense, this notion of mad narratives, which is to think of them as cultural adjustments. If we think about mad narratives as a cultural form of societal adjustment, in the way that we have physical adjustments such as wheelchair ramps, but here the adjustments are in the cultural domain. So there are ideas that if they were to repopulate our cultural understanding, they would bring benefits to a lot of people, to make sense of difference and to make sense of a wider range of human experience. So the idea of mad narratives as cultural adjustments is perhaps a helpful way of trying to think about the extent of the social change that is required. And to really conclude, I want to end with a really beautiful kind of turn of phrase, which I heard in a movie that I went to see recently, a documentary actually called Crazy Wise, which I really recommend. One of the individuals who were interviewed in the movie, she was referring to distress and extreme and unusual mental states, and she said that there is a kind of arc or narrative that wants to unfold in the psyche. And what I believe clinicians should do is to provide the right amount of guidance such that the arc or narrative can unfold in a way that is meaningful to the person going through these experiences, while at the same time retaining some basis in a shared mad narrative, and for them to be able to offer this guidance in a context that is safe and ethical. There's no question that this is a challenging prospect for mental health clinicians, but it is what clinicians should aim for. The alternative to this is to prevent this arc from unfolding, to silence it, to ignore it, and to do so can be harmful. Thank you for listening for my talk, and I really look forward to your questions. Thank you.
Thank you, Dr. Rashad.
Yes, I can hear you fine.
Interesting, and we have a lot of great questions and comments. So can you hear me okay? Okay, I had my microphone on mute during this time so we wouldn't have echoes.
All the water,
yes. Thank you. We talked a little bit before the webinar about how warm it is in London right now. So I appreciate that you're needing all the hydration you can get, I'm sure. All right, I'm going to start off with one of the questions that came in early. Do you know why the original 70s movement, the one closest aligned with the civil rights movement, never really caught on with the political left? Judy Chamberlain famously tried to interview Noam Chomsky, but he refused.
That's a really interesting point. I don't know the answer for this question, but it's I'm quite surprised that Chomsky was so dismissive of the issue. That is quite interesting in its own right. I'm not really sure of that particular bit of the history of the 70s movement, so I won't be able to really comment on that.
Okay. Julie has another question. Excuse my throat here. Do you think there's a shift beginning to happen within psychiatrists? Are psychiatrists seeing their failings?
It is a great question.
To be more critical?
So on one hand,
what are your thoughts on that?
As some of you perhaps are familiar with a lot of debates happening on social media at the moment, in which you have like kind of orthodox psychiatrists, let's say, arguing with critical psychologists and critical psychiatrists, and the debates are really terrible to watch. Everybody's entrenched in the position, misrepresenting the position of the other. So on that front, I'm afraid there's not much progress happening at all on the social media front, which perhaps has something to do with the platform itself. I myself, I haven't practiced psychiatry in several years. I do full-time research now, but obviously I do have friends from the time when I trained who are still psychiatrists, and psychiatrists work within. Some of them are quite diverse in the way they approach things. So they look at social issues, they refer to psychology as much as they can. But the entire framework, of course, and the entire training of psychiatrists is essentially still embedded in the biopsychosocial model. So they would not be very receptive to alternative narratives of madness, as I have been discussing today. And part of what I hope to achieve is, now that I've completed my research, I'm going to be running a series of workshops with various mental health professionals who work, like really full-time in the NHS, to introduce them to some of the concepts which I discussed today, and to really begin to inject some ideas into mental health practice. So I wouldn't say that things have changed radically at all at the moment, but hopefully they will in the near future.
Thank you. Uh, John Herbert in France uh, says, it seems to me that my will to be proud of my madness was it says claustrophobic, but I wonder if it should be catastrophic. But maybe John can enter something on consensus around me to make me as sedated as possible in order to disempower me as much as possible in my social, family, and
Um,
political contexts.
I'm not sure
And
I
this
understand
happened
fully
with
the
John from
comment.
an extremely early age.
Can you help me, Bob? I mean, what is it exactly you're referring to?
Yeah.
I can see it. I can see it now. I'm looking at the right-hand side. Yeah,
Well, I'm,
I'm
I'm
trying to
not
read
sure
it, so
either. Can
trying to
I
see
don't
what
know
it
if you
means.
can see the comment. I cut and pasted it in our.
Is he referring to the treatment that he received, in a sense, like the?
I think so. Yeah. And I'm looking to
Okay,
see in the other
I'm
chat
not really
box whether
sure of what I
John
can
is
say about that
responding, but I
comment, to be
think that's
honest.
what he's referring to as personal experience.
Okay, sure. I think it'd be good to clarify it a bit more.
Maybe that's one we can work on a little bit later after the webinar and talk some more with John about it. So yeah. Vertebrates comments. I think that individual and social are being represented
Yes.
as unrelated, and I don't think it's such a
No,
dualistic
absolutely.
process.
I
And
think
she asks if you can
it's
speak to
it's
this.
not
I
a
think that's
dualistic.
from
It's not a dualistic
early
process. It
on in
just
your
it helps
presentation.
to, when one begins to tries to analyze a particular situation, it helps to break it down into a range of analytic concepts. But of course, it doesn't mean that in practice you can fully disentangle your individual from your social identities. But in terms of thinking about it and perhaps moral and political relevance, it helps to have these concepts to play with in order to be able to think things through. For instance, when you think about individual identity, I said it has a collective dimension and the personal dimension. And the collective dimension is the one that is the subject of political debate and disagreements and arguments and fights, in a sense, whereas the personal dimension is not so much. For example, if I understand myself as a kind person or a selfish person, that doesn't really have much political relevance. Whereas if I understand myself as gay or as Egyptian or whatever, this can have political relevance. So these are just analytic concepts to help us think through particular problems, as opposed to let's say uh, like ontological kind of entities which are totally separate. It's just simply about thinking through the problem. That's a good point. Thank you.
Okay, thank you. uh, Lynn makes a comment. Comprehending the violence in all capital letters of professional language is so accurate and a good contrast to what she says is the false, inaccurate documentation which occurs, with
That's
the
an
author
excellent
being
point.
completely protected in the records,
One of
no
one of the
opportunity to
I
comment
think the
usually.
one of the things I learned really when in my few years in practicing psychiatry was that I saw how this process happens, and um, it's a terrible process because in a way the clinician has all the power to, they can write whatever they want, put it this way, in the notes, and they can twist things around in a sense that makes the person more unwell than they are, or more well than they are. It's so in any direction based on their perception. And I'm not saying it always happens in an intentional way, but it is in the nature of people when they come to write something down that it will always be colored by how they want it to look like. And so it's quite an it's a very true and poignant comment, really, that this is really what does happen. Yes, I agree.
It would be interesting to know if anybody's had experience with asking, demanding to have comment into their clinical record. I assume that it may have happened somewhere, but it's certainly not a very common practice, I
Yes.
don't think. And so it'd be interesting to know if anybody's had experience with asking for that, pushing that
Yeah.
issue. Travis Atkinson comments that Clay's perspective aligns with Dr. Russell Razak's perspective from his book, Breaking Down is Waking Up. It's funny how people with psychiatric experiences 2,000 years ago were often
That's
called
a really interesting
prophets,
point. I
and
think
now they're often
the movie, the
villainized and
documentary, sorry,
marginalized.
Crazy
Do you
Wise,
have
which
a
I was in
comment on
a
that?
screening for it, and organized by an organization called Mind. You must, of course, know about Mind in Camden. So they had a screening of Crazy Wise, and I think this was their message. I think this is a really serious issue, and it's a really serious problem as well, because in a way, it's a symptom of a general cultural emptying of our culture of these notions, of these spiritual notions. So we don't really have anymore in our communities the idea of going on a journey, a spiritual journey, or having an experiential journey in a sense. The only context where this makes sense is like in terms of psychedelic drugs, say. But we lost the notion of a spiritual journey. So the culture is not really receptive to this notion anymore. So when someone begins to have this kind of idea of breaking down, the only resource and institution that society has managed to organize to deal with this ended up becoming mental health services, and that kind of shows that also there is, there's a cultural responsibility, if you like, that we need to try and become more open and more receptive to these experiences, and not just, like leave it all for mental health services to deal with. So it is a problem, but it's hard to know how it can be reversed. How can you bring back spiritual notions into the culture so that when people have these experiences, people understand it in this way? So it's a difficult question.
The next one is another question comment from Julie, who asked earlier about whether you saw changes in the world of psychiatry, whether they're starting to wake up to some of the issues you're raising. But she says, how do you think we can help psychiatrists understand that counter to their training, integrating voices can be seen as more helpful by many people who've had those experiences? Do you think
That's a
psychiatrists,
good point. I mean,
again,
I
will ever
think
get to a place
the
where
Hearing
hearing
Voices
voices will
movement
not
has
be
been particularly
pathologized?
successful in terms of producing amazing research, amazing documentaries, and actual real difference to people's experiences. So the Hearing Voice movement has been one of the more successful uh, movements in mental health activism. Um, I think there is definitely, how should I put it, there's a softening in terms of psychiatrists and voices. Before it was, if you hear voices, then this is definitely pathognomonic of something pretty serious. But now there's a much more acceptance, I think, that if you're able to converse with the voices, and if the voices are benign in a sense and useful, and you can get along with them, this is considered to be, it's okay. But of course, there will be individual variation. Some practitioners will be extremely worried when the person reports they hear voices, and some practitioners will be much more relaxed about it, and they will worry more about the content of the voices and the person's relationship to them and what the voices are saying. So there's a difference between voices, for instance, giving command hallucinations, which can be harmful, and voices which are supportive and give useful information the person can use. But I think in general, there's more subtlety now in the way practitioners understand and deal with voices than there was before. And I think a lot of it really is attributable to the work of the Hearing Voices movement.
Good. I want to come back to a comment by Dr. Mark Sherry, but first, Berta Britz had a Hearing Voices Network comment, and she says HVN places voice hearing in a social context. Looking at
Yes,
clinical,
I agree.
continues to place focus on individual and maintains power differential and meaning making. So, so yeah. Okay, Dr. Sherry's comment. How would this discussion of clinical encounters change if we more fully integrated the race, class, gender, sexuality inequalities which underlie both the diagnostic
That's a massive
process and the
question and a
clinical
very important
encounter?
one.
Another great question.
and
I'm not sure if
not
there's a clear
100%
answer, but
fully,
what is your thought on that?
within my field of research expertise. But of course, it's really interesting. It's not just really the clinical encounter. I mean, of course, I can talk about the UK context, for instance, on the intersection of race and the clinical encounter. I don't know if you're aware, but there is a massive review of the Mental Health Act going on at the moment in the United Kingdom. The Mental Health Act, I don't know what the equivalent is in the US, but it's basically the act on the basis of which you can place individuals under a section and take away their freedom. And one of the main reasons that the review is being conducted is that there's a disproportionate number of black British men being admitted under a section, disproportionate to any other demographic. So, at least on this level, there seems to be significant issues in the way that black men are assessed, in the way that their experiences are understood by the clinicians, most of whom are not black in the UK at least. So, of course, all of this gets more complicated once you bring in different dimensions. The idea of class is relevant, I think, more so relevant in clinical psychology and in certain kinds of psychotherapy, which are very homogeneous class-wise. Most clinical psychologists and therapists in the UK tend to be middle class, upper middle class, and most of the patients they would see in the NHS would not be. They would be more working class. So there's a clear class differential here, which creates problems in understanding and problems in being able to make full sense of the person's experiences, which can end up resulting in misrepresentations and in not necessarily helpful treatments. So it's a really good point, and I think these categories intersect with the clinical encounter across all stages in really complicated ways. So thank you.
Julie asks a question that's more or less personal, and that is, have you experienced pressure within your own profession? Have you been pushed out or seen
I left psychiatry
within the
in a
profession?
sense.
Do your colleagues take your approach seriously?
It was. I mean, it's interesting to reflect on this. I mean, I left psychiatry because I became so involved in research, and it became really clear to me that this is how I can try and do something useful, which can be more helpful in a sense. I was very dissatisfied with the practice of psychiatry. I felt that a lot of effort goes into what you do on a day-to-day basis, but it doesn't really translate into helping people in the way that you want to help them. But whether I'm seen as radical within my profession, I don't know. I mean, my friends who are psychiatrists, they're very they're very self-selected samples. So, and they've been hearing me talk about these issues for a very long time. So they don't see me as radical. But I do remember one experience I really had in the very beginning of my training, where we were sitting in a ward round with the consultant, and there was someone else there, the patient in this context, and I began to. The consultant told me to present the case, as you say, and I began to describe what the person told me in her own words, using her own terminology. So I refused to use any diagnostic terms or any bizarre constructions. And the consultant stopped me and said, "You cannot say that. You have to use our language, because this is what this is our identity, and this is who we are." And this was it really did put me off, because in a sense, if you can describe the problem in a way that makes the person feel at ease, then really this is what you need to try and do, But it was kind of it made me realize that that this is what I should really be expecting from now on. Thank you.
Thank you. John asks a question, maybe more in the form of comment, but
Absolutely.
How can someone else decide for one what is?
Of course. I mean, I think what I've been trying to actually I've said several times during the talk is this idea that the MAD narrative is a sort of blueprint. It is a helpful idea that some people might find some solace and some understanding in, but some people might not. In that sense, when I spoke about broadening our cultural repertoire by introducing different ideas about madness is to make so is to give people a choice in a sense. So when you are going through these kinds of experiences, there'll be more ways available for you to understand what's happening to you. And in order for this to be possible, these ideas, these mad narratives, will need to kind of become part of our cultural understanding. But at the end of the day, it is a very personal process, and it cannot be forced in any way.
All right. Elizabeth says, thank you for this talk. I see the benefit of including mad narratives in the clinical encounter. However, how can we be sure this inclusion doesn't represent or lead to co-optation? Could inclusion of mad narratives in psychiatric or psychological disciplines lead to making these narratives less
that is an excellent point, and
incorporated into
we have seen this kind of in a sense, haven't we, with the whole notion of recovery, didn't we? Like, what began as a positive notion, it ended up being one other thing, another, in a sense, problem or another way to blame individuals for everything that's happening to them. I think, in a sense, when I was talking today about the kind of concepts that need to inform the encounter, so it would be more amenable to mad narratives, and I spoke about secondary insight and identity making. I think the hope is that if clinicians begin to think in terms of these concepts, then co-optation would be less likely to happen, because in a sense you would understand that the task that that is before them has to involve the person in an immediate and direct way. So you're no longer kind of doing things to the patient or suggesting things to them. You're working with them, trying to help them develop a certain kind of understanding. You're supporting them. In terms of the last sentence I ended up with, which you can see in the quotes here, you're helping them. You're helping this arc or narrative to unfold in their psyche in a way that makes sense to them and does not end up with them completely isolated or alone. So I think the clinician who would see the benefits of mad narratives and would be able to work with them is the kind of clinician who would be less likely to co-opt these narratives and transform them into their own agenda. That would be the hope, at least. But this is something that we can't really predict.
Andre asks a question that I've had some involvement with myself. When I was mental health commissioner in Oregon, I started what we called a peer bridges program in the state hospital. And it's evolved into about a 10-person team of people who are peer services recovery. And they're very concerned about working in an inpatient setting, how peer supports can be co-opted. But Andre says, I've found what is currently branded as peer support useful and would seek to overthrow the implicit power in inequalities that characterize clinical encounters, which continue to individualize and
I was looking for the comment. Let me just read it again. 1 second.
Depression I've experienced. Can you?
Yeah, absolutely. I mean, like the comment about the peer support being useful, right? By Andre. I think that's absolutely right. I mean, when I mentioned here these different mental health groups and networks, I mean, ultimately, a mad narrative is a shared narrative. That's precisely where its power and use comes from. But it's a shared narrative that is not constructed by professionals, but it's constructed by people with lived experience. So obviously, peer support here is a perfect context where people can begin to share stories and construct an idea about what's happening. So I completely agree that peer support is extremely useful, and it goes along with what the idea I've been promoting in this talk.
Thank you. Emily picked up one that I didn't see, and it's from Seth Farber.
Seth Farber.
R.D. Laing was probably the most well-known creator of mad narratives in the 60s and 70s. He also used them to make a cultural critique of society. The same was true of the Icarus project. Could you comment on this, its
Yes, I mean
implications both
the
for madness
the
and for
Lang
social
was very famous.
change?
You know, he was always mentioned in the context of this idea of schizophrenia being a breakthrough, not a breakdown, wasn't he? He was kind of a popularizer of this notion. But I think, in a sense, perhaps Lang was kind of more concerned, or not more concerned, but his reach was mostly for other psychiatrists. I don't see that Lang's idea changed, you know, much in culture or society. I think if you want to change society, then activism, um, grassroots activism, you know, is really the way to go. Lang was a very bright intellectual and a theorist, but what is really needed is more activism, and is to try and influence practitioners in their actual practice. Um, in that sense, I think the Icarus project is doing really great work, and especially with their narrative, "The Dangerous Gifts," which I spoke about today.
I have to admit that I'm having a little trouble catching up with all of the great comments and questions that are continuing to come in. And I think part of what we're going to need to do is see if you have
Should I look at
some
a couple of
opportunity, a
questions
little
myself
time
and
to
try and
help
answer
us
them,
look
or
at them after the webinar itself, Dr. Rashad.
Oh, okay. Okay, well, perhaps
Yes, that would be great. We have about 2 or 3 minutes left, so please.
there's Sanya says, have to comment on the cultural loss of spiritual journeys. Can you please acknowledge that we are not all Western civilization? Um, so yeah, I'm not sure what Sanya's comment is. I mean, she's saying the idea of oh yeah, I get it. Okay, I think Sanya is referring that when I said that we lost the idea of experiencing a journey, I was really referring to maybe perhaps what she is referring to as Western civilization. Of course, not in all communities around the world has this notion been lost. So yes, I agree with Sanya. Hannah has a long comment saying, as I journeyed through the mental health system, I came to understand the narratives taught to me by professionals that I was an illness, as my experiences were so much a part of who I am. It wasn't until I met a therapist who opened up to other possibilities, that my experiences may have been life supporting and allowed me to survive, that I was able to actually start to live in the world. So yes, I mean, I think this is really great to hear. It's great to hear that there are practitioners and there are professionals who are more open to understanding the person's own story and trying to connect them with individuals who will be able to help them make sense of this story. I think professional narratives have the problems that I mentioned in this talk, and they really cannot satisfy many people because they cannot really speak to the experiences that they are going through. Okay.
Well, Dr. Rashad, thank you very much. I'm wondering if you have any closing comments that you'd make summarizing some of what you've told us. It's been an excellent presentation, and just seeing all of the comments and questions that have come in.
Thank you very much, Bob, and thank you to all the attendees.
Webinar. So I want to thank you. And
I really enjoyed this. It's the first time I do a webinar on the internet live, and it's been a really great experience. And I hope there were, you know, something useful for you to take from this. And I wish you all the best. And thank you, Emily, and thank you, Bob.
Okay, thank you very much. Yeah, and I want to thank everyone who participated. And we will be uploading the webinar, so you can watch it again if you want to, parts of it. And if you have colleagues who are interested, assure them that if they weren't able to be part of this today, it's a little less interactive for them, but they can still watch the webinar. So thank you. And Emily, thank you very much for your work behind the scenes.